Hello, everyone. Thank you so much for coming. I see a lot of people jumping in. This is awesome. 7 o'clock on the dot, punctual. I love it. Welcome, everybody. Thank you so much for coming. It is 7 o'clock, so we are going to get started to respect all of your time. So, good evening, everyone, and a welcome to Attention Deficit Hyperactivity Disorder Adults and Kids. Brought to you by NAMI Cook County North Suburban, Dr. Joshua B. Nathan, the Great Lakes Regional Medical Director at LifeStance Health and the Des Plaines Public Library. LifeStance operates in 33 states and has an office in Highland Park, Illinois. LifeStance Health offers a range of mental health services across the U.S. Patients can choose both online and in-person appointments. More information can be found at www.lifestance.com. Before we begin, I would like to take a second to thank the Des Plaines Public Library for sponsoring this event. The Des Plaines Public Library's mission is to be a catalyst, advocate, and place to advance the vision and ideals of the Des Plaines community. The Des Plaines Public Library is located at 1501 Ellenwood Street for those interested in stopping by. Thank you so much for your support and for making this event happen. We truly appreciate your partnership. I am Bree Hoekstra, the Program Director at NAMI Cook County North Suburban. NAMI, or the National Alliance on Mental Illness, is the nation's largest grassroots mental health organization, providing public awareness, no-cost support, and education programs online and in person so that people and families affected by mental health conditions can build better lives. We are a lifeline to individuals and families who do not know what to expect in their difficult life journey. We offer classes, support groups, and do a lot of local advocacies for mental health. Our programs are free and open to those in our community service areas, but we do not turn anyone away who is in need. We are so pleased to have you all here tonight. Thank you so much for coming. This year, each month, mental health professionals will dig deep into a variety of mental health conditions to provide further education, to raise awareness, to fight to end the stigma that surrounds mental health. For our topic tonight, Dr. Joshua Nathan will further educate us on attention deficit hyperactivity disorder, or ADHD, in adults and kids. Specifically, to understand what ADHD is and what to expect from seeking a psychiatric evaluation for concerning symptoms, to become aware of the categories and risks of various medicinal treatments, and to be able to seek additional information about having and managing the disorder. According to NAMI National, attention deficit hyperactivity disorder, or ADHD, is a condition characterized by inattention, hyperactivity, and impulsivity. NAMI National also states that an estimated 8.8% of children ages 4 to 17 have ADHD, and an estimated 4.4% of adults aged 18 to 44 have a diagnosis of ADHD. Finally, National states with treatment, people with ADHD can be successful in school, work, and lead productive lives. Dr. Nathan will give an overview of the symptoms, diagnostic process, and treatment. He will also explain the complexities in diagnosing and treating ADHD, as well as dispel myths related to this disorder. Lastly, he will share additional resources and information. Our Q&A will be held at the end of the presentation. However, if you would like to type your questions in the Q&A box, please do. Our guest speaker tonight, Dr. Joshua Nathan, is responsible for LifeStance's psychiatric care in Illinois, Michigan, Wisconsin, and Minnesota, as well as the clinical associate professor at the University of Illinois College of Medicine in Rockford. Dr. Nathan previously worked in leadership as National Medical Director for a telehealth startup specializing in adults with ADHD and Behavioral Health Medical Director at the Lake County Health Department and Community Health Center. From 2010 to 2018, Dr. Nathan worked as faculty at University of Illinois at Chicago College of Medicine, rising to director of the Mood and Anxiety Disorder Program and co-chair of the hospital's Clinical Ethics Committee. Dr. Nathan currently serves as chair of the Illinois State Medical Society Council on Economics, serves on the APA Committee on RBRVS, Coding and Reimbursement, and represents Illinois on the APA Assembly. He was the president of the Illinois Psychiatric Society, or IPS, from 2018 to 2019, and is a Government Affairs Committee member since 2014. In 2020, he was awarded the IPS Community Service Award and was recognized as Distinguished Fellow by the APA. Additionally, this past month, Dr. Nathan received the Illinois Psychiatric Society 2024 Commitment to Physician Wellness Award. Dr. Nathan completed medical school at UIC and psychiatry residency at Brown University. He is married to Deborah and is the proud parent of two delightful boys, Eli and Jared. We are so thrilled to have him here tonight to further educate us on this ever-important topic. So I am honored to welcome our guest speaker, Dr. Joshua Nathan. Thank you, Doctor.
Thank you so much, Bree. Well, it sounds like a lot and a little embarrassing actually to hear it all read back to me. But thank you very much. I really, really appreciate that. Welcome, everybody. And I was thrilled to be asked to do this by NAMI and to have a topic that I have a lot of experience with and to be able to talk to people, educate people, and really hopefully actually dispel some myths in addition to it. Okay, so we're going to be talking about attention deficit hyperactivity disorder in adults and kids, right? And you'll see that for the most part, that's kind of one and the same, right? All right, let me just, oh, there we go. I have to share. I did that again. Hold on just a moment. Give me just a second to, give me just one moment. There we go. Hold on a moment. There we go. Okay. And, okay. I did this when we were practicing too. Okay. All right, there we go. All right, let me go back to the beginning. Okay, attention deficit hyperactivity disorder in adults and kids. All right, and just a little bit about me. You already heard some of the kind of details about what I do for both a living and as a volunteer. A little bit about my ADHD street cred. In addition to what you heard before, as a national medical director at a startup called Ahead, where we've initially focused on people with ADHD, later tried to branch out into other things. When I was at UIC for a number of years, I tried to start an adult ADHD clinic. And there was a researcher there, Dr. Stein, who was an expert researcher. I had very little experience with working with adults with ADHD, and so we tried to start a clinic. He ended up moving away, and the clinic ended. I, for many years, was teaching psychopharmacology of the treatment of ADHD to UIC psychiatry residents. And I bring up the fact that I was a co-chair of the clinical ethics committee, mostly because at one point while I was doing that, I actually organized a special lecture dealing with the ethics of using stimulants specifically for performance enhancement, which is a topic we'll actually get to a little bit later as well. And most recently, in my ADHD cred, I have been involved with an APA adult ADHD focus group to talk more about what is it we need to help people with ADHD, to diagnose it, to really sort of help the population that's out there that's seeking treatment for this. Right, and because as we'll talk about, there's really no standard guidelines, right? And so we're trying to develop those standards and all those tools that are really needed for adults in particular, but more broadly too, right? And so really a lot of the information I'm saying comes from my practice, but also from talking to other clinicians, other psychiatrists and psychiatric practitioners, but how they've approached ADHD over the past 20 years as we've learned more and more about this illness. right? So that's a little bit more about my street cred there. Okay. I do like to give a little bit of a warning that we will talk about ADHD, but also many other things that sometimes can be a little triggering. So we may talk about symptoms of other illnesses as they're relevant that may lead you to just be reminders of your own experiences or otherwise sort of be somewhat emotional for you. Okay, so just a little bit of a heads up as we go through this. All right. Okay, moving on to the next page. All right. Hopefully by the end of this, you'll have a general understanding of ADHD and what to expect when seeking treatment for it. Okay, and attendees will be aware of the categories and risks of various medicinal treatments and other treatments as well. Okay, and attendees will be able to seek additional information, right, about having and managing the disorder. Okay, all right, so first, a little terminology to clear up. Okay. I know people hear the terms ADHD and ADD. Before we get into anything, I just want to clarify that ADHD is really the current term, and there's a couple subtypes. I'll go into some more detail about those in a minute, but ADD was an older term, and it's just a little phased out, but just to be clear that for all intents and purposes, they're equivalent. We just don't really use the ADD term as much anymore. Okay. All right. Moving on to the next thing. All right. A little bit more of an overview. Okay. All right. There are, as I mentioned before, three subtypes, right? So it's ADHD, and then there's a predominantly hyperactive type, predominantly inattentive type, and a combined type, right? As you heard some statistics from Bree, about somewhere between 2 to 5% of adults have ADHD. It really depends on which study you look at. And probably 3 to 10% of children. And literally just last week, maybe 2 weeks ago at this point, the CDC released the results of a study that estimated there's actually 15.5 million US adults with ADHD, and that 25% of US adults think they have undetected ADHD, with only about 13% of that 25% have ever discussed it with their doctor to see if they actually have it. Okay. And in terms of the causes of it, which we'll talk very, very briefly about, but we do know there's a lot of genetics involved, and there are some environmental exposures and risks that can lead to the onset of ADHD as well, or make it more likely. All right. Okay, moving on. All right, some more diagnosis basics. All right, do that. Okay, we know that the signs and symptoms of ADHD start before the age of 12. If the signs and symptoms begin later, they really have another cause, and we'll talk about what that could be. And importantly, for it to be ADHD, those signs and symptoms cannot have another cause. So drugs, medication, trauma, other psychiatric illnesses, other medical problems can be causes. And we'll talk about how those can impact the diagnostic process. And also importantly, the symptoms have to be impairing. So they're severe, persistent, pervasive. And by persistent, we usually mean continuous since childhood. As an example, if somebody was impaired as a child, but then not in college, but then later, again, had difficulty, really no longer ADHD, if assuming that whole time it was never treated. It has to be pervasive, has to be in all areas of a person's life, right? Strictly speaking, at least two, but typically really in all areas of their life. And severe, meaning it's causing significant functional impairment. Okay, so those are some of the baseline things we need to know about ADHD. I'm going to go to myth number one. All right, one common myth is that some people have adult onset ADHD. The term adult ADHD refers to people who have it as an adult or I'm sorry, still have it as an adult, or only get the diagnosis as an adult. But nearly 100% of studies that were thought to show adult onset ADHD were actually found later to not have adequately assessed childhood presentation of symptoms or didn't assess for them at all, right? So ADHD is considered a neurodevelopmental disorder, thought to represent a delayed development of the brain of the brain systems that are responsible for attention. We'll talk a little bit more about that later, right? But there is no such thing as adult onset ADHD. Next slide, here we go. All right, I am going to try to play this video, all right? So before we get into the signs and symptoms, all right, sometimes it's helpful to illustrate what we're talking about. I can use words all I want, but it's so much easier to show you. So this is a little video. It is, I like to say that it's in French, but there's no actual words, so no translation is needed. We've been playing around with the sound. I've been told it's a little faint, so I hope you'll bear with me and try and listen carefully as I play this video, which I think is a good illustration of ADHD, of hyperactivity in particular. Okay, all right. Hope that was somewhat illustrative, and I actually will try to reference it as we go forward about some of the symptoms and signs we saw in our little ladybug friend, to sort of help illustrate some of the points I'm going to try and bring up later. Right, but I think it's a cute little video, no translation necessary despite appearing to be made in France by the Disney Channel, of all things. So, all right, let me move on to some, to the next slide. All right, and talk about the actual symptoms. So moving in from an illustration, a cute little video, to actually talking about the details and what I would look for. So when we talk about inattention as one of the core symptoms, right? For children to have inattentive type, they have to have 6 of the following symptoms. Adults only need 5 to meet the minimum criteria for a diagnosis. All right. And what that includes is people finding that they are forgetful in their daily tasks, losing things that they need for tasks, struggling to complete things they need to do, or just don't follow through on things that they've started. They appear not to listen when they're being spoken to. They are easily distracted. People with ADHD with inattention as part of their illness make a lot of careless mistakes, typos, misspellings, leaving words out when they're writing things, other types of careless mistakes. Difficulty organizing activities. I want to be clear, it's not organizing your stuff and belongings, but organizing activities. People with ADHD and with inattention often dislike doing any activity that involves mental effort, especially sustained mental effort. And they really just have difficulty sustaining attention to activities. Basically, often we'll describe it as getting easily bored. Right. So the video we illustrated, we showed, didn't really show any of these things. Right. But these are sort of the core inattention symptoms. And one extra note, when we talk about getting easily bored, I want to note in kids, that can mean that they get bored after a few minutes, right? They're doing one thing for a few minutes, drop it, do the other thing, right? Really kind of always chasing that new shiny object. But in adults, it's a little bit different. And we're usually talking timeframes of months or years even. So they may have difficulty maintaining long-term relationships or frequent job changes. We'll talk about that in a little moment, right? So both can get easily bored, adults and kids, but it may look a little bit different in each. All right, let's talk a little bit about hyperactivity. All right. And the ball will stop moving eventually, but to give you a little another illustration of hyperactivity and a sort of a corollary to it, impulsivity. And so for children to have hyperactive type ADHD, they need to, again, to have 6 of the hyperactive or impulsive symptoms. And adults, again, only need 5. So for hyperactivity, we're talking about fidgeting or squirming in your chair, right? Really have a hard time sitting still. And definitely have a hard time staying seated specifically, right? So we kind of saw that with our ladybug who just couldn't stay in line, right? Runs or climbs excessively. We saw the ladybug bouncing on the snail, and bouncing on the flower, whatever it was. Okay. Having a hard time remaining quiet or playing quietly, right? So ran into this cool, housing structure, walked in and blew its bugle mouth, whatever that was. All right, so hard time playing quietly. Often in motion, right? Really like driven like a motor, so just seems to sometimes constant motion, and typically they talk excessively. I mean, these hyperactivity symptoms could be adults or kids. Impulsivity is similar, can look similar, but we kind of try and categorize it a little bit differently. When we talk about impulsivity, we're talking about blurting things out, not just talking excessively, but talking over people, interrupting people. Difficulty waiting your turn. So standing in line is, can be brutal, right? And not just answering questions before they're completed, but just generally interrupting, not even when there's a question, just talking over people, interrupting their friends, family, talking out of turn in school, right? So that's sort of the kinds of things that we're talking about, right? Kids in school. So if you take these combined kids in school, they don't stay in their seat. Often we'll see them getting in trouble with their teacher a lot. They'll get sent to the principal because they interrupted the teacher. They didn't stay in the seat. They were doing something else besides paying attention to what the teacher was doing, right? So those are the kinds of things that we may see in school. And in adults, friends may notice, hey, like they never stop talking, and they always interrupt me. And friends may comment to you, family members may comment that to you. You may get that feedback at work, right? So it's in multiple settings, you may get that feedback or notice it yourself. All right, see the ball did stop moving. Okay. And some common features, right? These are not diagnoses, right? And that's actually important to keep in mind. These are features you may see. So I consider them kind of soft signs that they may be a problem, but you often see these things with people, with adults. Emotional ability. So many people think it's a symptom of ADHD. It's a common feature, but it's not necessary for diagnosis. Relatedly, poor anger management. So there can be some irritability with ADHD. There can be frequent job changes, as I talked about before, again, because they get bored over time, or they just struggle in their job. They're less likely in general to get married, typically have shorter term relationships and so forth. There's increased frequency of divorce for adults with ADHD. Adults will have been less likely to have completed high school or to complete college. Increased risk of criminal behavior, typically decreased lower income and productivity. And people with ADHD, adults in particular, tend to be accident prone. That is actually very much the case with kids for sure as well. All right. And then some more common features that are all ages. I mentioned accident prone or injury prone. Low self-esteem is really, really common in this population, especially if it was untreated as a kid, and they continue to have it as an adult, but it can still be there as a kid as well. In part because there can be often some social impairment, both as children and adults. When you don't hear what people say, when you miss out on things, it can create some social difficulties. And sometimes the other kids can be pretty brutal if somebody's pretty hyper and doesn't sit still. Many people with ADHD have sleep impairment. Pretty interesting. We'll talk about that a little bit later, but it can actually sometimes get better when you treat the ADHD. It typically gets better, actually, even when you use stimulants, which we think of as being counter sleep. All ages typically have low frustration tolerance, so really not just impatient, but when things don't go well, they can struggle. And people with ADHD at all ages have a higher rate of depression, substance abuse, anxiety disorders, really any other comorbidity. In fact, I tell most people that if you have ADHD, having another illness, another psychiatric illness is much more typical and more the norm than not having it. Right, so we call it a comorbidity, is more the norm than the exception. Okay, so all right, so these are some common features, not part of the diagnosis, but common. All right, so myth busting number one. I can't focus or concentrate, so I must have ADHD, right? So I'm going to say that that's false, right? As mentioned earlier, to have ADHD, symptoms cannot be caused by anything else. So in some ways, ADHD is a diagnosis of exclusion, right? The objective signs and symptoms alone do not mean you have ADHD. Right? So it just means you have symptoms that could be ADHD, but they could be many other things. All right, what else can it be? So same symptoms, you can have that, or very similar from a descriptive standpoint, can be caused by a learning disorder. So difficulty learning to reading or math may lead you to have difficulty actually in multiple settings because you can't read in school and you can't read at home, right? So you think you have problems in multiple settings. People with anxiety very often have ADHD. We'll get back to that in a moment. because it's very complex. But people with generalized anxiety can think they have ADHD because they're worrying all the time and not focused on what's going on around them, get distracted by their worries specifically, not just by random other things. Social anxiety disorder, obviously, if you're socially anxious, you can't pay attention in conversation. And so it may seem like, oh, you're just drifting off. Right? But what's actually happening is anxiety. OCD, I've had many, many patients who thought they had ADHD, but when we kind of drilled down to what was really going on, had severe OCD. And as soon as the OCD got better, their focus and concentration was completely normal. And so it's really important to know that, what's really make sure there's not something else going on. PTSD, especially any sort of trauma, and we'll talk a little bit more about that too in just a moment, can often look like ADHD. And chronic major depressive disorder. I say chronic because a single episode, you probably won't think you have ADHD, but it can go on for years. Mania, for sure, sometimes gets mistaken for ADHD and vice versa. People with psychosis can appear distracted and have those same symptoms. People with marijuana dependence or just overusing it, so abuse, can have same symptoms. Alcoholism, sleep apnea, the same. Other medical problems, low testosterone, low or high thyroid, both can look like ADHD, have the exact same symptoms, and many, many other medical problems, right? And then there's some normal processes or responses to things that may give some of the same symptoms. So people who are perfectionists, I have many patients who can't concentrate because they literally need everything to be so perfect. So they're always kind of anxious that things aren't going perfect. And so that leads to distractibility, sometimes things taking a long time, being inefficient, and they think they have ADHD. Boredom is a common problem. Loneliness has lots of data lately, lots of reports lately about loneliness in the general population. Unsatisfying job, disliking school, poor comprehension, low self-esteem. These are struggles and stresses that people can experience. They are not necessarily the result of illnesses or disorders, but sometimes can lead people to think they have the symptoms of ADHD. Kids may experience abuse or bullying or other types of severe stress. And that too can be mistaken as ADHD, right? And so I want to sort of highlight that a little bit more in particular, okay? Severe stress, right? In adults, that can be job losses, financial constraints, a death in the family. In kids, we generally call it something else. In kids, what we're talking about are what we call adverse childhood experiences. These are often missed and treated as ADHD in childhood. Part of the reason is things like divorce, marriage, food insecurity, poverty, parental illness, frequent moving, many other things. The parents may bring their kid into a pediatrician or a child psychiatrist and say, I think my kid can't focus or concentrate. I think they have ADHD. The parents do not necessarily talk about the arguing and fighting that's going on at home or the problems at home that the child may be reacting to. Right. So and so just like any other type of severe stress can cause the symptoms I just described that can also represent ADHD. And so to make it even more complicated, when we're talking about severe stress and PTSD and anxiety, things in that spectrum, if a child has ACEs, adverse childhood experience, we often call them ACEs, and sees a doctor for those symptoms, right? It doesn't mean they may be having those symptoms that the pediatrician thinks are ADHD caused by something else, a reaction to the trauma and stress around them. Kids who are experiencing stressful things cannot focus, they can act out, they may have trouble sitting still. How they experience stress and anxiety can look the same as many other types of problems. So it can be assumed it's ADHD now and treated that way. But the other thing is that ADHD can cause stress, anxiety, and difficulty socializing. And so it could be that the ADHD what is really ADHD is mistaken for something else. In adults, the same thing. So as an adult, you may be experiencing symptoms of PTSD and trauma, which looks like ADHD, or that's, the problem causes problems with focus, concentration, sitting still, so forth. It doesn't mean the person doesn't have ADHD, and even more so. So if you have ADHD, you've had it for a long time, you've never had treatment, now you're an adult and you're trying to get things done and have a family and job and mortgage and all those kinds of things, ADHD is going to be very impairing, cause you to feel anxiety, cause you to have distress. And the stress and anxiety can cause worsening of those symptoms of inattention and focus and concentration. So they really play off each other, right? Untreated ADHD can lead to anxiety and distress and problems. Anxiety can cause symptoms that look like ADHD as well, problems with focus and concentration. So it can be very, very tricky to tease those two apart. More importantly, as an adult, right? If I see an adult who's thinks they have ADHD, they can't focus, they can't concentrate, and I ask about their childhood, they may tell me that, yeah, I had trouble focusing and concentrating and when I was a kid as well. But I also was moving a lot. My parents got divorced and they were fighting and arguing, and I had a parent who went, who was very sick. So there's a lot of distress going on. What that means is when I look back and try and understand if the illness was caused, oh, I'm going to go back to that in a moment. Okay. If I try to understand whether they had those symptoms as a kid, um, they may have had those symptoms as a kid, but now at this point, I don't know the cause, right? They may have had ADHD back then and had stressful life circumstances. But in the present, as an adult, it's really hard to tease those two apart. Okay, so we'll come back to that as well. All right. So, all right. All right. So how do I know what I got? Right? So complicated, right? What I say is go see your doctor, right? Come see me, come see another psychiatrist, see a psychiatric nurse practitioner, see somebody who can really help you go through those symptoms and talk to you, right? So you go see your doctor. What are they going to do? They're going to do a full psychiatric evaluation, right? They're going to get to know you, understand your current symptoms, current problems, what you're experiencing, both the difficulties you're having with focus and concentration, understand the details of that, understand how far back they went and what else may be a part of causing those symptoms. They may do some screening tests. Certainly with many adults, we'll use an ADHD rating scale, a GAD-7, which tests for screening for anxiety, PHQ-9, which is a screening for depression, right? So you want to look at other things that are present. In kids, typically we'll get a screening tool that asks the parents what symptoms they see, as well as ask teachers or somebody else in the child's life what else they're seeing. Those Connors is one of the names, and there's a few other names for those scales. Right, so we really try and use scales as much as possible to get a sense, a screening for current symptoms, right? But really a psychiatric evaluation is key. One question that comes up a lot is, do I need neuropsychological testing? Great question. And the answer is you don't need it. All right. And so you don't need neuropsychological testing, and I'll explain some of that in a little bit. But the what's going to happen, and we'll talk about treatment in a little bit, okay, is you may see this psychiatrist and they're going to ask you all these questions. And at the end, they may have a good sense of what you have. You have ADHD, you have anxiety, or as I've often said to many people, especially with that history I said, right? I think you might have ADHD. I don't know for sure, but I know you're currently depressed, or I know you're currently have anxiety. So let's start with those things. Sometimes it's very clear that the anxiety came on a lot later and the ADHD was there as a kid. No childhood issues, no childhood distresses, definitely some anxiety now. But the symptoms of problems with focus and concentration and other ADHD symptoms have been there throughout, right? So sometimes it's more obvious than others. If I'm not sure what's going on, basically I'm going to pick a place to start treating. And I'm going to treat the anxiety or treat the ADHD. If I treat the ADHD and the anxiety gets better, right, it really means that that anxiety was secondary. It was caused by the distress of having ADHD, of not being able to function in your life as well as you should, right, and the distress that that causes. So it's pretty remarkable. We'll talk about in this a little bit, that you can give somebody a stimulant medication, for example, that can cause anxiety. But if you see somebody's anxiety come down, pretty interesting, right? Similarly, if I'm not sure and I start treating the anxiety and the focus and concentration gets better, I have my answer. The problem is anxiety and not ADHD. If the anxiety gets better and the ADHD is still there, the problems with focus, concentration, not sitting still are still there, then I have another answer. Anxiety has gotten better, and now we have another problem to deal with as well. Okay, so it can get very complicated. Neuropsychological testing really is of limited value. All right. So myth number 3. All right. I think I'm on number 3. I got tested and it diagnosed me ADHD. I got a test. All right. And so this is actually a myth. Right. They will put a diagnosis on there. I mean, and good neuropsychological testing will do all the history taking and history screening that I mentioned. So sometimes it is more thorough than other times. But the testing itself, the paper and pencil things that you do not actually tell you for sure that you have ADHD. They're information and about what you're experiencing now. So in most cases, testing is neither necessary nor sufficient to diagnose ADHD. The testing provides some clues. It can demonstrate current deficits in certain cognitive domains or functions. And those domains or functions are thought to be indicative of ADHD, right? But it cannot prove the cause of those deficits, and it cannot say when they began, right? So it can show the deficits, but those deficits, again, can be caused by many, many things, right? And as an example, my son was diagnosed with ADHD, but no testing was necessary, right? So actually a psychiatrist who won an award as being for being a great psychiatrist, which I did not know before I saw her. But no testing was necessary. They did some screening tools that were used to collect data from teachers and from us, but no testing, right? So not necessary in adults or in kids. It can be informative, and I will say there are some situations I do refer patients for testing when they have problems with focus and concentration. They have symptoms, but I think they have a learning disorder, or I am not so sure that what they're concerned about symptom-wise is out of the range of normal. So I've had some patients where I did send them for testing, and what we found out is that their symptoms, they didn't have symptoms, that their ability to focus and concentrate, even in those tests, to sustain attention were within normal limits, right? So not only did they not have ADHD, they didn't have any symptoms. Okay, and then I've had other illnesses, other times when, nope, it sounds like they're doing okay in their life. I can't quite tell, but testing showed that even in the present, they do have symptoms when it wasn't totally clear. Okay, all right. So that's myth number 3. All right. So to remember, to remind everybody, signs and symptoms begin before the age of 12. It is a neurodevelopmental disorder, right? So as I'm seeing patients, the age of onset is very important, right? Again, relates to the concept that ADHD is a neurodevelopmental disorder, a delayed or arrested development of the attentional function of the brain. So if the symptoms started later, it is not ADHD, right? And that means we have to know about childhood experiences, and testing does not cover that. We have to screen for other medical problems, including other psychiatric problems. Neuropsychological testing does not cover that. And the impairment is persistent, pervasive, and severe. And the testing does not cover the degree of functional impairment or the pervasiveness of it. All right. Okay. So a little about how it's caused, the cause of ADHD. Right. Moving on to that. My doctor diagnosed me with ADHD. How did I get it? Right? So the truth is, and this is about as technical as I get, I think, on these slides. We really don't know a lot about the causes of ADHD. We know a few things, right? We do know it is a neurodevelopmental disorder, right? So as I said, delayed or arrested development of the attentional systems of the brain of some kids' brains. And some kids, their brains are just delayed, right? So they catch up by late adolescence or adulthood, and they're able to focus and concentrate like people who don't have ADHD. And for about half the kids who have ADHD, that development is actually arrested, right? And it never really happens, and they just continue to have a deficit into adulthood. It may look a little bit different, okay? And every other function of the brain can develop normally, but just that ability to focus or concentrate or to sit still and not be hyper. We think it's likely related to the frontal lobes, which are mainly responsible for things like response inhibition, delaying delaying aversion. Okay, I'm sorry, an aversion to delaying things, right, and delaying uh, um, uh, things you want. So, you want cookies, cake, and basically, delaying an aversion to delaying things you want or need, right? That can look like impulsivity. Executive function means planning, sometimes judgment, right? And um, and so those things are obviously deficits. Those are controlled by the frontal lobes. So we presume that most of the deficits in ADHD have relate to some aspect of function in the frontal lobes. We know that there's a gene environment interaction. Um, we know that some genes involved are related to dopamine and acetylcholine. All right, those seem to be involved as well. We'll talk about a few other genes that may be involved as well, which is kind of interesting. Um, or actually, let me say now. So we know that there's some other genes that are um, uh, cause risk that also seem to be the same risk genes for schizophrenia, autism, borderline personality disorder, and a few other illnesses. But we're not sure what those genes do. um, some of those genes seem to be related actually to um, visual processing and eye tracking, movement tracking with your eyes. There are some that seem maybe to be related to circadian rhythms. We're not totally sure, right? So, okay. And so those are some of the areas that may be affected genetically. We know that in terms of environmental factors, um, in utero exposure, so fetal exposure to nicotine or alcohol causes an increased risk of ADHD. In early childhood environment, if there's psychosocial adversity, poverty, parental mental illness, parental discord, other adverse childhood experiences, there's an increased risk of ADHD. Right? So we know that certain genes related to neurotransmitters like dopamine and acetylcholine can be involved. There seem to be some genes that maybe are related to visual tracking, and it could be that problems with circadian rhythm are involved. Um, the onset can be impacted by many other factors, but you don't necessarily have to have exposure to nicotine or alcohol to get ADHD. You don't have to have an adverse childhood environment to have ADHD. It can onset anyway. Even without that. All right. Okay. All right. So you may not really care how you got it, but for those who do, I went through that. Um, but now let me go through kind of what do we do now? So you have ADHD. What are you going to do about it? All right. So there's really two categories of treatment I'm going to talk about. One is compensation, right? Behavioral strategies, and the other is medication. All right, so let's talk about compensating first. Okay, so all right, so myth busting number 4, medication is the only thing that helps with ADHD. Not true. In fact, medications are the only thing. Medications can help, but they never help the entire disorder. They don't take care of every aspect of the illness for anybody. All right, so they may help you focus, they may help concentration, they're not going to stop you from getting bored easily, right? As an example, most typically. All right, so another myth busted. All right. So let's talk about strategies people use, right? For sure, regular diet and regular exercise and healthy diet. Regular exercise in particular has been shown to very much decrease the symptoms of ADHD and the severity and burden of the illness. When it comes, say, to healthy diet, great question in terms of what that actually means in reference to ADHD. There's not a specific diet I've seen that I would recommend, but basically just eating a healthy diet and whatever you think that means. Um, uh, you know, uh, more good fats and uh, fewer bad fats, more good complex carbohydrates and fewer bad carbohydrates, and processed sugar and things like that. Good amount of protein, right number of calories. Right. So in terms of more specific strategies, having to-do lists, can be very helpful, making sure you just write down things you need to do on a regular basis and checking them off. Taking scheduled breaks if you have to work for long periods of time, really planning out those breaks, knowing I can work for 30 minutes, I can work for 45 minutes, and I'm going to stop for 5 to 10 minutes or 15 minutes. Using a standing or treadmill desk if you have to be at a desk for a while can help you be more physically active. and easier to pay attention. Technology, using it smartly, so reminders, time to leave notifications, things like that. And the one thing I recommend to a lot of people, if you have ADHD, if it's well treated, maybe you're okay. But like I said, there's very typically residual symptoms. It is okay to seek accommodations from school or for work. I definitely encourage many physicians to get accommodations around writing notes and things that can help them be more efficient at that type of job. Okay, so don't be afraid to ask for those things for your child if they have ADHD, or at your job if you have ADHD. Okay, and so we're going to move on to the next type of treatment. Compensation, not doing it. What else can I do? All right. Well, there's medication for sure. And there's two types of medication. Very cleverly named stimulants and non-stimulants. All right. It's always a funny thing to me when you're naming something by what it's not. It's like fiction and nonfiction. Okay. I actually always feel like with nonfiction, like these are writers. They could have come up with a better term than just what it's not. But anyway. All right. So stimulants and non-stimulants. We will talk first about stimulants. All right, I'll go a little bit over them. Right. We will start with the stimulants, and there's really just two types of stimulants, right? So two types of treatment, medications, compensation, and behavioral strategies, two types of medications, stimulants, non-stimulants, and really just two types of stimulants. All right, so the first one is methylphenidate, right? That's a broad category. Next is amphetamines. Now I put a third one on here. Technically, there is a third one, methamphetamine. It is related to amphetamines. You can prescribe methamphetamine, literally, it's called digoxin. I actually have talked to some psychiatrists who have prescribed it. I do not. All right, so I'm going to take it off of there. I'm going to put a pseudo third other stimulant called modafinil. That's the generic name for the medication. I'll talk about it. It doesn't really help much, so it's only a pseudo option. Okay, so, all right. So let's talk about ADHD medication in more detail. So I mentioned there's basically methylphenidate and mixed amphetamines. Two medications, about 30 different brands, right? I am not making that up, right? Actually, by this count, we'll see 29 different brands. So you'll see on this list is a long list of brands, 15 different versions of methylphenidate. And really the only difference, we're talking about different manufacturing processes, different delivery mechanisms, different technologies to make them last longer, and most importantly, different durations of action, how long they last, right? 15 brands, one drug. How do we choose? We'll talk a little bit about that, but it has a lot to do with cost. The ones that are bolded here are the ones that are generic, the others are not. Um, um, but also basically lifestyle, right? Um, Stimulants, by and large, methylphenidate and amphetamines are considered first-line treatment, right? But they may not be the right choice for everybody. Okay. All right. And there is some data to report that methylphenidate is less addictive than the other class, amphetamines. It may be a little bit less likely to be a little less likely to be addictive, but also maybe a little less likely to be effective, right? Generally considered safer from a cardiovascular and abuse standpoint, right? So this may be one reason we want to try and choose methylphenidate over amphetamines if we're going the route with stimulants. All right. Next type of stimulant, amphetamines, one drug, 14 versions. So 29 in total for those who are doing the math, right? Again, the difference between one version and the next is the duration of action. Again, different manufacturing processes, also different delivery mechanisms, different technologies to make them last longer or shorter. And most importantly, like I said, different durations of action. A couple notes about this. So this seems to be more addictive than methylphenidate, so more likely to be abused and diverted. Maybe a little bit more likely to be effective, and generally considered slightly riskier from a cardiovascular standpoint, as well as from an addiction and abuse standpoint. Okay. And again, you can see all these different versions. I am not going into details about this, but you can see some of the different things. And this is the same with the methylphenidates. We got sprinkles here, we got liquids here, we got ODT stands for disintegrating tablets, oral disintegrating tablets. We got patches, something called a prodrug, just different ways to make the drug last longer. All right, and different ways sometimes of manufacturing it. Okay. All right. And another myth here, stimulants help me, so I must have ADHD, right? The fact of the matter is, stimulants help everybody. Um, Certainly, they affect everybody, which is kind of the definitional for an addictive drug. So even if you don't have attention deficits or hyperactivity, they are likely to help you. They can be performance enhancing or simply promote alertness. And we know that that is a big part of why they get diverted, misused, or have people have what's called non-medicinal use or non-medical use of these medications, right? So, and importantly, they are highly addictive, right? And they tend to, if you take them and it helps you, they tend to make everything seem nice for most people. That is one of the big properties of an addictive drug. So naturally, you take it once, there's a high chance you will want to take it again because it helps you in the moment and it felt nice. Okay. So always advising caution when starting these medications. All right. Myth busted. All right. Let's talk about some of the risks in a broader sense. All right. So except modafinil, right, doesn't really have these risks. So methylphenidate and amphetamines are Schedule 2 controlled substances. All right. And a Schedule 1 to 5. I always forget if there's 4 or 5 schedules. One means you cannot, there's no medicinal use for it. So this is just one step from that. Same category as opioids. There's a high, so you cannot your doctor cannot fax a prescription, can't call in a prescription. You can't put refills on a prescription. There's a high risk of addiction and abuse, as I was just talking about. Cardiovascular risk, there's a very, 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 very rare risk of sudden death at therapeutic doses. From 1992 to 2006, there was a total of 10 sudden deaths in adults, not in kids. And it is not known if in any of those cases, if there was any pre-existing cardiovascular conditions. It is thought that in most cases, there probably was, right? We know it can raise blood pressure and pulse. And there's a new data that came out in the past 2 months, I think, that talked about some long-term risks, increased risk of cardiovascular disease, including hypertension, stroke, and heart attack, and people who are on stimulants for a long time. Right, so to put that in a slightly different category, untreated ADHD puts you at risk for anxiety, depression, and substance abuse, as we talked about. Treating it with stimulants puts you at risk for a possible risk for hypertension, cardiovascular, stroke is cardiovascular accident, I should say, so CVA or stroke. MI is myocardial infarction or a heart attack. Right, so you're at risk for a cardiovascular disease on the one hand, a risk for other problems on the other hand. So it can be a tough choice. The risk for cardiovascular disease is really relatively low, even though it's slightly increased above the rest of the population. So there's no guidelines for cardiovascular monitoring specifically, but I will say most doctors do check heart rate and blood pressure on a regular basis if you're taking a stimulant. Pre-treatment EKG, so a heart exam including the EKG. Some insist on doing it, but in my practice and talking to many other psychiatrists, it's really based on age and risk factors. So if you're 50 and never been on a stimulant before, it is probably good to get an EKG beforehand if you haven't had one recently. If you are 30, young and healthy with no cardiovascular risk factors, you do not need one. If you are in between the ages of, say, 40 and 50, and you maybe have some risk factors, it might be a good idea to get that. Risk factors can include being obese, having high blood pressure, having a family history of early sudden death, things like that. So it depends on your cardiac history. Okay. All right. All right. The last stimulant, modafinils. There's Provigil and then R-modafinil or Nuvigil. These are not addictive. The DEA put them as Schedule 4 for really no good reason. Basically, DEA is like, well, they're stimulants, so they must be addictive, even though nobody knew how they worked at the time. And the DEA does not change things quickly. So there's really no risk of addiction, but they're also not likely to be effective. And they mainly promote alertness, but not really attention. So I include them on here, but don't spend a lot of time on them. Non-stimulants. Um, this is a pretty broad category. And so I'm not going to go into detail into too much about each of them because that would be a lot. Atomoxetine and viloxazine are similar. They mainly impact a neurotransmitter called norepinephrine, which used to be called noradrenaline. Atomoxetine is actually similar to older antidepressants called tricyclics, but when they tested it for depression and anxiety, it didn't really help with those things, and it found new life in helping people with ADHD. So it does work, and it's available as a generic. Viloxazine is a newer brand, and again works in a similar mechanism as the atomoxetine, but it's really only available as a brand name right now called Qelbree. The alpha agonists work similarly on norepinephrine systems in a different way. They started life as blood pressure medications. They have an immediate effect. They're very safe. They're not addictive. Um, they're mainly helpful for hyperactivity. There's better data in kids than in adults, but I have seen them be effective in both. And both are available as in generics. And just real quick note, these are always funny names that we're using and throwing out. Strattera, Qelbree. I actually have a patient, and I was telling him how I think my two favorite areas of marketing are drug names and car names, because none of them make any sense. They're just silly made up words. And he joked that the way he actually remembers the name of his medication was that he remembers to take his Chevy Strattera. All right. And so we joked a little bit about, oh, that's really great, Chevy Strattera. It does actually sound like a car. And we joked whether it was really a Chevy or a Buick, but right, these very silly names. But Chevy Strattera is a good way to remember the name of one of them. That's really stuck for me for sure. All right. And a couple other medications you may see commonly used, right? Off-label non-stimulant medications for ADHD. Bupropion goes by many, many names. Wellbutrin, Zyban, when it was marketed for smoking cessation, budeprione for FeVO, which I think is just the 450 milligram dose. So there's a brand name for just one dose. The only official indications for bupropion are depression and smoking cessation, but there's really good data for using it for ADHD. It mainly works on dopamine like the stimulants, but in a different way. So bupropion is not addictive in any way, shape, or form. Discipramine is an old tricyclic antidepressant. There's actually surprisingly good data on it for ADHD, but it is not very commonly prescribed. Venlafaxine, more commonly known as Effexor, but also other brand names like Pristique, has an FDA indication for anxiety and depression, not for ADHD, but there's some good data with it. Okay, and lastly, I'll say that there's other medications that work through these same technical mechanisms, right? Work on the same neurotransmitters in the brain. And so it's very possible that your doctor may suggest medications that work in a similar way, even though they're not officially indicated for ADHD. Okay, so we do have that ability and try those other things. All right. Okay. So myth busting number 6, I think this is my last myth, right? ADHD medications equals stimulants, right? That is definitely a myth, right? The choice of medications, including stimulant versus non-stimulant, and which type of which medication depends on many factors. You want to look at your individual risk of addiction, cardiovascular risk, your age, your genetics, and for sure your lifestyle, all right? And when it comes to genetics, a really good way to ask about genetics is if it worked for a parent or your child or your brother or somebody you're a first-degree relative, especially, good chance it'll work for you. Not universal for sure, but it's a good chance it'll work for you, right? And also important to consider your lifestyle. What do you do for a living? Do you have 12-hour days? Do you have a regular 8-hour workday, right? Okay. And that's really the best way to choose. Stimulants are considered first line for sure. We'll talk about why that is here. Okay. So to compare, all right, stimulants versus non-stimulants. Stimulants are very effective. 80–90% of people who take them will have an effect except for modafinil, right? Versus about 2/3 of the people who take a non-stimulant. Right. And I will say that is a big difference, right? Stimulants can be profoundly life-changing for many. So it's one day you're struggling, the next day your mind is clear and you're able to focus, right? So it's really hard to ignore that impact and why one of the reasons people they are considered first line. Right? I've actually had patients cry to me because they're so grateful for this sudden change in their life and their ability to function, right? So I've had patients just talk about their mind feeling quiet for the first time ever in their life. Right. So we're really lucky to have treatments like these for sure. And for a person with ADHD, it's great. For me, it's wonderful helping somebody so profoundly. Right. That being said, doesn't help everybody, and there's problems. Okay. And at the end of the day, there are a lot of factors to consider. Right. So, for example, stimulants have an immediate effect. That's really cool. There's non-stimulants that have immediate effect, but some have delayed effect. I will say with stimulants, there's a time-limited daily effect. So it starts and then it stops, and then you don't have it in your system the rest of the day. And I'll add to that to prevent tolerance and that same drug becoming less effective over time. I actually have people skip days. So you may not even be able to take it every day, right? So versus a non-stimulant, once it's working, if it works, 24/7 effect. If you're awake, you can pay attention, right? You have to think about cardiac risk with medications. Stimulants can worsen sleep, especially if they're taken too late. I will say, sometimes if you adequately treat ADHD with a stimulant and you don't take it too late, some people actually, their sleep actually gets better. Both medications can worsen anxiety, so that's just a potential side effect. All right. Non-stimulants have no risk of addiction, no tolerance to the effect. So one version of addiction is tolerance, meaning the same dose becomes less effective over time. You have to increase the dose, and really that can cause risk because the dose keeps going up and up and up. All right. Non-stimulants do not have any of that risk. Stimulants do. Stimulants are narcotics Schedule 2. There are prescribing restrictions, and as many people are probably aware of, there's been huge shortages lately. Right, that wasn't a problem a few years ago when I used to talk about this, but it certainly is a problem now. Okay, so these are all the things that we consider when we decide which medication is the right for every person. Right. And lastly, I think I'm on my last slide. Okay, some resources. All right. For general information, chad.org is a wonderful resource. Chad is like is the main source for all things ADHD. So a lot of the info I presented here came from there. Directory of people who treat ADHD. Truth is, I don't have no idea what CHAD stands for anymore. I think it's like children with ADD. I think was what it came for, like CH and then ADD, but I don't know. APA is great, obviously, diagnostic and statistical manual. A lot of the symptoms and presentations and the criteria I talked about came from the APA. They have a good information page about that. Coaching resources. So when I talked about compensation strategies before, one of the best things to do is get some coaching, right? That means somebody saying, hey, let's talk about what works for you and let's perfect that, right? So some great coaching resources. One is How to ADHD, which is a YouTube channel, which was created by Jessica McCabe. She's actually an actress and writer, but she did a fantastic job with this YouTube channel. And many ADHD experts refer people to that. Attitude Magazine, ADDitude, I'm not making that up. It is an e-magazine, has great articles, and there's even a podcast, ADHD Rewired. I'll be honest with you, I have not listened to the podcast, but I've had many patients tell me that it was really, really helpful and useful for them. In fact, actually, I believe I heard about the podcast originally from a patient of mine. Okay. All right. And that's it. Oh, and my timing was pretty good. We're right at the 61-minute mark. Okay. All right. Pretty cool. All right. So questions, and hopefully I have some answers for you too. Would you like me to unshare the video at this point?
Sure, up to you. It doesn't matter. Thank you so much, Dr. Nathan. We really appreciate your time. That was very informative. We actually do have a couple of questions already in the Q&A box. If you think of a question, please don't use the chat. The chat will not be, it's disabled right now. So if you do have a question, do it in the Q&A feature at the bottom of your screen. The first question does say, do you do if a child on medication is unable to eat during the day, during the school day until the medication wears off? Is it okay for the child to only eat one time per day?
That is a great question. Yes, and if it is a side effect I forgot to mention about the stimulants is the appetite suppression. It is quite profound for many. I do treat adults. I don't typically treat kids, and so for a lot of the adults, they're like, "Oh, I'm not eating. It helps me lose weight." Okay, which is a slightly different issue altogether, but for kids, it can be a big problem, especially when they need to eat, to grow, and so forth. So, and just for learning. I would say, generally speaking, it is not okay for kids to eat once a day. Right? I have had when I have treated kids or young adults, um, that it was a big problem. They would have to eat a ton in the morning, then they would take their medication, and they just really would not want to eat until the medication wore off. So they really had to time their eating around the medication to get enough food in. Um, so my answer to that would be honestly is to uh, part of the really interesting thing about all those different stimulant medications is that even though technically they're the same one, sometimes you need to think about a different medication, a different version, even of the same medication, just around lifestyle, right? So I try to avoid some of the shorter acting ones because they do tend to be more addictive, but if it allows them to eat breakfast, lunch, and dinner, right? Because one wears off and then they take the next dose, you may need to do that. You can consider non-stimulants for sure. I actually had one patient who struggled for many years. He took Vyvanse, which is a long-acting version. It was really the one that felt the best for him. It was the most comfortable in terms of the onset of the effect and the offset, but he struggled to eat, and he was a scrawny 19-year-old kid. And we decided to try atomoxetine, and his what he noticed was that it wasn't quite as effective as the stimulants. The intensity of the effect was not as much, which is a common report for many people. But he was so happy to be able to eat on a regular basis that he was willing to sacrifice a little bit of the effect and the potency of the effect just to be able to eat on a regular basis. Right. So that's my answer. So not really okay for a child to eat just once a day. They need the calories, they need to grow. And so it's really about finding that regimen that works best, or finding a way to work around, eating and nutrition. Okay.
Thank you so much, Dr. Nathan. Next question says, is violence toward the mom while pregnant a risk factor for the child developing ADHD?
Um, Not that I know about. I have not heard of that type of. I will say that in children, obviously, when mom is pregnant, certainly some jealousy and things like that can happen. So it's not an uncommon thing for a kid to be aggressive towards mom in that situation. And for the um, child, there's uncertainty. What's the new baby? What's coming out of mommy? Mommy looks different. Okay, mommy's more tired, all sorts of things. So there can be aggression toward mom that is common. Obviously, how normal it is might depend on the intensity, but I have not heard of that in particular as a um, indicating a likelihood to develop ADHD. I would say it's not, definitely that's not going to cause the ADHD. I'm assuming you're talking about in the child who is the one who's violent, not the one that's in mommy's tummy. Um, but um, uh, um, but the but I haven't heard of that being an indicator that a kid will have ADHD. Okay.
Mm,
All right.
thank you.
Cool.
See, do we have any more questions from our audience? I do have a question for you as I was
Mhm.
kind of listening to your presentation, thinking about those psyche evals. How much does that cost typically? Are there variations? Does insurance cover that?
Yeah, if that's needed. So the neuropsychological testing, and it depends a lot on the testing that's done. I would say in most cases, it's out of pocket. If you didn't have insurance, it would probably cost, I think, $3,000 to $4,000. It's pretty expensive. I mean, it's a half day of testing plus all the time to score it, and the reports they write up are very extensive. And so it can be very costly. In most cases, insurance will cover it. Um, and this is a lot of the advocacy work that I do. I mean, in the state of Illinois, any health insurance regulated by the state of Illinois has to cover mental health. By federal law, they have to cover it on par with every other medical problem, right? So if every other sort of medical issue, including specialty care and general medical care. So it's illegal for insurances to restrict your access to that if it's regulated by the state, for sure. And in many cases, if it's regulated by the federal government, and it's complicated who regulates what. Okay, so I always actually advocate if your insurance company is not paying for it, file a complaint. File a complaint with the Illinois Department of Insurance and say, hey, this isn't being covered. Okay, but for most commercial insurances, they will cover it. Medicaid in the state of Illinois, I'm going to say 99% sure will cover it. Medicare is actually interesting because it does not always, and in many cases, it does not cover it. I think there's been a change in that recently, but for Medicare, it's a little bit different. It's usually more around people with dementia, and so it didn't used to get covered, but I think that's changed.
Very good
Um,
to know.
oh, will the
Um,
slides be shared? Okay.
let's see. I missed
Um,
says, will the slides be shared? I missed the part about stimulants versus non-stimulants and the time frames of eating associated with certain medications. Can you repeat, please?
yeah,
So
slides can be shared.
perfect.
Absolutely. Okay. And that's not a problem at all. And I'll add in as far as the eating goes, it is a good question, and I know I'm regretting I didn't put that information on there, but um, uh, eating is tough. So especially for kids, right? Obviously, we need them to eat, and so that's can be a big problem around children. Making sure that you time medication around eating so that they can eat enough, right? And many kids will just eat tons of food at the end of the day, or tons of food before they take their medication. But shorter acting medications can also help them eat in the middle of the day. It is actually worth noting that even in adults, um, there are many stimulants that are used both on label and some stimulants and off label with other stimulants to treat eating disorders. So some of the versions of stimulants we saw are used to treat conditions like binge eating disorder. Um, Phentermine is a medication many people have heard of. It's actually a stimulant. It doesn't seem to help much with ADHD, but it works through a similar mechanism as methylphenidate or Adderall or amphetamines, and it's used again as an appetite suppressant. Right, typically for either for weight loss specifically or for binge eating disorder. Um, so they're not, I don't know if it's a great use for those medications, but they have been used that way. Phentermine in particular, although I didn't talk about it today, some of the older people listening may remember fen from a long time ago, which was really dangerous. And there's deaths associated with it, but fen was a combination of fenfluramine and phentermine, which I just mentioned. Fenfluramine, it turns out, was the dangerous part. Phentermine was actually a much safer medication. So phentermine has come back into fashion as being used for weight loss. Right. I know we've gotten a little off the ADHD topic, but
No, it's very
okay.
interesting. I did have a question. I don't see any other questions in the Q&A, but I do have a question. So we've been hearing that, anxiety and depression levels have been increasing in children and adults, post-COVID, and just in general, right? And so
Mhm.
when we're seeing that rise in these other mental health conditions, are we also seeing a rise in ADHD being diagnosed? Because a lot of people can, mistake different conditions for that and vice versa.
I think there's been an increase in the diagnosis of ADHD. I don't know if it's because of things that have happened in the world in post-COVID era. I don't know if it's that there's more attention to it. No pun intended. And Um, but I think that what happened certainly during COVID is that when you got locked in your house and the normal and there wasn't a lot else to do. People found out that they had ADHD. They couldn't sit and do things. And where it may have been socially acceptable in the type of job or the thing they got into before, it became a lot harder, right? When they were just on a screen all the time, couldn't get up and walk around and take those breaks as easily, or didn't have the different environments that they were in. So if you have ADHD and you get bored easily, it's kind of nice to be at home and then at work and then traveling and you're in different settings and things change on a regular basis. So I think some people became aware of the difficulty they had or more aware of it. It's like, well, it's a kind of a problem before and then it became more of a problem. Um, so I think there was more diagnosis of ADHD, more recognition of it in that time, and also more access to care for ADHD and people getting evaluated for it. I think there's been some overdiagnosis of it. for sure, because I think people get depressed and have anxiety, and now they can't focus and concentrate. So there's been increases in those illnesses. There's definitely been an increase in people thinking and presenting with the question of having ADHD because there's more depression, because there's been more anxiety. Um, so definitely increasing people asking about that. The rates, as far as we know, haven't really changed per
Mm,
se over time, but it does
mhm,
seem like there's more recognition of it, for sure. And a better recognition, in fact, that adults have it. When I was in training, which was over 20 years ago, we didn't talk about adults having ADHD.
mhm,
Kids had it. It was something you got as a kid, and it disappeared by adulthood. That's what I was trained. And then over the past 20 years, it's like, well, maybe 10% of adults will have it. And well, then a few years later, it was maybe a quarter, maybe 50%, and so the change the idea that it can last into adulthood has changed over time. The
mm,
current numbers we've had in terms of rates have been pretty consistent over time, over the past, I'd say, 5, 10 years now. So
mm. Thank you. It's helpful. We got a few more questions.
yeah.
One says, can being abandoned as an infant, then receiving poor to no human contact until a toddler or older cause ADHD?
So that's a very interesting question. And I I would say that it is definitely a risk factor for the onset of ADHD. From a genetic standpoint, we don't know how many people have the genes for ADHD but don't get it, right? As far
Mm,
as we know, most of the people who have the genes for it will get it, from what we understand, from the what it looks like. But it's possible that's not the case. And there may be some people for whom those early childhood experiences can lead to the onset of ADHD, and somebody who might not have gotten it otherwise. Um, okay. And so it seems like that may be a risk factor early in development for somebody who had a risk of it, but might not have gotten it, might not have expressed itself in that person. Okay, so does seem to be an association there. We kind of talked about early childhood, adverse childhood experiences. So it's possible that some of those do lead to the onset of the illness. We know that those are risk factors. Let me back up. We know that those things are risk factors for having ADHD. Whether they cause the onset of it is definitely a harder question. I would
mm,
say that the circumstances you describe are very traumatic, right? And depending on the age, when you talk about an infant versus toddler, depending on the age that they became aware of what was happening and the exposure to those circumstances, that definitely could make a diagnosis of ADHD much more complicated, because those
mm,
traumas had happened. Those traumas would have affected the person's ability to focus and concentrate, behave appropriately, even as a child. And so it definitely could lead to those symptoms, but it would be hard to separate that exposure from having ADHD, right? So they could have,
mm,
right? So that does make the having the diagnosis trickier. As a kid, if it was a child who's presenting for treatment, you want to make sure that depression wasn't there, that there weren't signs and symptoms of other traumatic problems. And then if all those things were taken care of, you could definitely be assured that it was ADHD, right?
mm.
Okay. Um, okay, I'm actually able to see these questions, so
Oh, wonderful.
I'm I've arranged all my windows in such a way that I can.
That's awesome.
So is there any relationship between ADHD and the screen time in childhood? Great question. Um, I would say that's one area of this that I'm not as expertise on. Okay, so I don't want to misinform you. I do know that one of the theories we talked about was with circadian rhythms, and there's good amount of data on blue screens, particularly blue light from certain screens, that seems to affect circadian rhythms, right? So you got blue light from certain screens affecting circadian rhythms, and circadian rhythms possibly being related to the onset of being related to ADHD. Um, so there's some concern that those are related for sure. I don't know the level of confidence we have in that data. And right now, no, there's no warnings that I've heard about to say keep kids away from screens because it's going to cause ADHD. No one's
Mm,
putting warnings out like that right now. But I do know that those are some of the theories that people are considering. And even if it doesn't cause ADHD specifically, right? We talked about medical problems, medical causes. That could be an environmental situation that makes it look like somebody has ADHD, but if you break away from the blue light and the screens, would the symptoms get better? That could be what we're talking about. Okay, so it could be causing some of the symptoms, but not necessarily the illness itself, if that makes sense. Okay. All right, but that's still just sort of really early data and nothing that I would say with any confidence that those are connected. Um, I have a question around Vyvanse. Should it be combined with other medical? I would say, so should it? I wouldn't say it should, but it could be. And Vyvanse, like other stimulants, it's one of the one of the amphetamines. Specifically, it's something called lisdexamphetamine, which is a prodrug. So when you take it, the list gets cleaved off and it becomes dexamphetamine. Um, but it works like the other amphetamines. Most antidepressants work differently through serotonin and norepinephrine. And always advise caution, but certainly serotonin and amphetamines work through dopamine really do not have any direct neurochemical or brain interaction directly. I have plenty of patients who take both. The ones that affect the antidepressants that affect norepinephrine may have a little bit more overlap. Norepinephrine and dopamine are a little bit more related. But I do have patients who take both and it works out just fine. Okay, so always caution and some monitoring may be needed, but it's certainly safe to take those together. Okay. Are you saying untreated ADHD symptoms will improve and dissipate over time? I'm saying they could, and probably about half the kids who have it, that is what we think happens, is that it just kids outgrow it. Okay, so which is cool, right? So and I've actually had many patients who were like, I had ADHD as a kid, and they would talk about how hyper they were, and they couldn't sit still, and they said kind of by the time they were done with college, right now it's not a problem. They just don't have it anymore. Right? There are things that come up, like they can get depressed, and then they have symptoms temporarily. Like I think I have ADHD again. It's like, well, you didn't have it 2 years ago, so. So you wouldn't have it now. But even though those symptoms feel kind of similar, because now in depression, they're coming along feeling sad and being unable to do things and all the other, having no interest in things and all the symptoms that go along with this with depression too. Okay.
Okay.
All right.
Any other questions before we close out?
Okay. Any questions about? I know there's been stimulant shortages, and I know people. I'm a little surprised. That was actually the question I was anticipating the most was um, people
Why
asking
is
like,
that?
what's up with that? And I can try and address it a little bit. It's actually a good point for NAMI people, who I consider people who are part of NAMI to be great advocates. The stimulant shortages are very, very frustrating. And I don't have a great answer to how to manage them or deal with them. Most of my patients, it's about looking at pharmacies and see where they can get it. Sometimes, if you're getting 20 milligrams of one medication, breaking it down to two 10-milligram tablets, sometimes it'll help work around the shortages. The supply issues, as far as we know, the main cause of them are DEA regulations. And so it's really important to be aware of that. The DEA has been a really bad actor in a lot of this. The DEA sets regulations about how many tablets a certain pharmacy can order or have on stock at any one time, and they set manufacturing limits. So they've just told the manufacturers of Vyvanse and generic Vyvanse that they can increase their manufacturing. Again, right? So, but the reason they have set these limits is there was an opioid settlement, many people may recall recently, and as a result of that opioid settlement, the DEA was expected to restrict access to the manufacturing and supply of opioids. The DEA made its own decision to apply that to all controlled substances. And so they continue to do that, despite everybody telling them to stop doing that. So, okay. I have all three kids with GAD and two with ADHD. Do any ADHD meds also help with anxiety? Great question. In theory, yes. I will tell you in practice, I have not successfully achieved that. So one of the medications I mentioned as sort of an off-label, having an off-label indication is Effexor. Venlafaxine is the generic name. Brand names are Effexor, Effexor XR. Prestige is really a version of that. Okay. And that whole group, what we call SNRI, serotonin and norepinephrine reuptake inhibitors. So anything that works through that mechanism. Because in theory, those medications work on something called norepinephrine and another neurotransmitter called serotonin. Serotonin is well known, that's like in medications such as Zoloft and Prozac, to be helpful for anxiety. It works well. The norepinephrine part of the medication, in theory, could help with depression, but also help with ADHD. Okay, so all right, so that class of medications, I will say theoretically, could kill three birds with one stone: depression, anxiety, and ADHD. Um, I will tell you in practice, I've never seen that work out for I can't explain why. All right, but um, so I wish that was true. It is a little bit more typical um, to combine a standard treatment for ADHD with another treatment for anxiety. Okay, and those are okay. And I saw the extra question worried about side effects. I will say that even though there's the risks we talked about with stimulants, they are generally very safe. Many people take them for many years, if not decades, with no significant problem. We talk about tolerance, but I've had patients who take them for every day for many, many years with no significant difficulty. I recommend people skip a couple days a week to prevent that tolerance, but they are generally very safe. The non-stimulants for sure are very, very safe. The side effects, people get concerned about those, but the vast majority of side effects, especially for non-stimulants and some of the medications we're talking about for generalized anxiety disorder or other conditions, are annoying, maybe uncomfortable, but not dangerous. Okay. And so it's an important thing to consider, right? For the vast majority of things, it's always good to ask and make sure you got that confirmation from your doctor. What are the long-term risks? Great question to ask, okay, as well as short-term risks. But okay. All right. Sounds like I answered a lot of questions. I guess my talk was really good. So,
Yeah, that
um,
was awesome. Thank you
all
so
right.
much. We really appreciate your time. That was very informative and very,
Thank you
very
so much. And Bree, thank you
appreciate
so much for all your help in getting this organized and set up and helping
it.
me get this together. So,
Oh, absolutely. I do have a couple of closing remarks before we head out. So if you did enjoy tonight's program, we have a lot of upcoming programs, a lot of upcoming events that can all be found on our website. Our website is www.namiccns.org. Next month, we do hold these webinars monthly. And so next month on November 13th from 7 o'clock to 8:30, we will have Dr. Lysandra Lopez and Dr. Paula Young, who are both from Rogers Behavioral Health, who will further educate us on OCD or obsessive compulsive disorder. Our webinar in November is going to be sponsored by the Glenview Public Library. And then I did want to announce we have something exciting that we just launched. We just recently launched our Parent of Teen support group. So if you are a parent of a teen that has, any emotional, behavioral, mental health challenges, this group is for you. You do not have to necessarily be a parent. If you are a parent, a caregiver, or a guardian, this is also for you as well. It is free, it is virtual. It meets every second and fourth Thursday of the month from 7 p.m. to 8:30 p.m. So if you are interested in that, we cover topics such as anxiety, depression, and other mental health challenges. You can visit us at our website as well. And then finally, once you log off, you will see a brief survey. We do this for two reasons. One, so that we better understand your comfort level with tonight's topic, as well as provides us with the data that we need to raise money to continue providing our programs for free to our community members. So please, please, please take that survey. It will only take you 30 seconds to a minute, I promise. And so that being said, we appreciate your presence tonight. And we look forward to seeing you at another NAMI CCNS community webinar. Please take care of yourself and each other and have a great night. Bye, everyone.
everybody.
Bye, Dr. Nathan. Thank you.